Good afternoon, everybody, and welcome. I'm Paula Chatterjee. I am an assistant professor of medicine at the University of Pennsylvania, and I am delighted to welcome you today to our webinar, which is called Understanding the Safety Net, Where Care Occurs and Why Definitions Matter. We're so grateful to you for joining us today, and especially thank you to Arnold Ventures for sponsoring the research that really underpins our discussion. I'll just start by sort of level setting this conversation a little bit. At a 30,000 foot view, I think the US healthcare safety net is facing a pretty extraordinary moment right now. Safety net providers have always operated in this environment of constrained resources while caring for patients, some of whom have the greatest health needs and social needs out there. But I think today's challenges go somewhat beyond longstanding issues of financial pressure and workforce shortages, right? Policymakers are being asked to make decisions that will shape not only how the safety net is financed, but also who is considered part of the safety net, which providers should receive scarce financial support, and ultimately whether patients get access to care when they need it. And so those decisions are really happening at this time when state and federal budgets are under tremendous pressure. Medicaid and Medicare policies are evolving, and there's this growing attention toward things like accountability, efficiency, and value. At the same time, the populations that are served by the safety net continue to grow in complexity and scale. And so all of that makes it more important than ever to make sure that our policy decisions are really grounded in rigorous evidence. And so today's webinar is a follow-up of our last webinar sponsored by the Parity Center, which provided an important foundation for today's conversation. So just to quickly summarize our last conversation, we were lucky to have Chris Collar, Doug Jacobs, Chris Chen, and I talk a little bit about the challenges facing today's safety net providers, including perennial financial instability, but also sort of emerging challenges coming up under HR 1. And together, we think those discussions kind of highlighted some of the current pressures and showed how they are really not hypothetical. They're happening now, they're having real consequences. And so today's conversation is going to try and build on that. The question we kind of want to focus on today is might sound a little technical, but is actually quite fundamental. What we want to talk about is how we define the healthcare safety net and why that definition matters beyond semantics. Definitions determine what we measure and value as a society. They influence how we produce and interpret evidence. They shape which providers are included in analysis or payment reform. And so we are hoping to sort of have an evidence-based conversation to inform that. If we can be clear about the evidence, clear about our policy choices and the consequences of those choices, we think we can be in a stronger position to design policies that better support patients. So I'm really lucky and happy and excited to be joined today by two friends and colleagues, Amol Navate and Josh Lau. They'll briefly introduce each other, and then Amol will kick it off and moderate much of the remainder of our discussion. So let me turn it over to Amol to get us started.
Sure. Hi, everyone. I'm Amol Navate. I'm a physician and economist at Penn, a professor of medical ethics and health policy, and I also serve in the role of chair of MedPAC, the Medicare Payment Advisory Commission. Josh?
Apologies there for technical difficulties. Josh Lau here, a general medicine physician. I'm a professor at University of Texas Southwestern Medical Center. I'm also a national physician executive at Ascension, where I lead technology focused on population health.
Excellent. So let's get started into some of the content. And I think, one of the key pieces that I think underpins much of safety net policy, as Paula said, to some extent, we're talking about definitions here, and definitions sounds really technical, but really it's a basic foundational question of, so who is comprising the safety net? In other words, which are the providers? Which are the hospitals? Which are the clinicians? Which are the practices that are delivering care to underserved populations and populations perhaps that have greater social needs or greater other needs? And so one of the core ways in which we've seen this play out at the national level is oftentimes dictated by this notion of dish policy. So disproportionate share. A lot of this really focuses on which are the hospitals where plays out the most, where hospitals are actually caring for a lot of Medicaid patients. And are they potentially offering uncompensated care? So providing care to underinsured or uninsured people, and therefore they have financial responsibility that they can't really recoup. So that is one kind of definitional construct that started in the context of hospitals. Now, obviously, we have a chart that we're showing in front of you. And one of the really key parts that we've explored as part of the work that we've done is, well, we have a good sense in a general way about which hospitals get classified as safety net versus non-safety net. But what if we take a somewhat similar construct and say, let's look at which outpatient practices, think about this as medical groups, primary care physicians, and others who are caring for people in the community. And which of those are really taking care of a disproportionate number of those who are dually enrolled in Medicaid and Medicare. So dual eligibles obviously oftentimes are an important population that policymakers care about. And so what you see here in this chart is that there's actually quite concentrated. So this is a curve that some folks might be familiar with called the Lorenz curve. And basically the idea is that if every practice took care of the same number or share of duals, then we would have that perfect 45-degree line that you all see. But instead, what we've done is we've actually plotted the practices based on their share, starting essentially at the right-hand side of this chart and moving to the left. So we rank them based on their concentration of duals, basically amongst the patients that they see. And then we plotted this from right to left. And you can see that this curve has a bend to it. And that bend actually is important because it's identifying that there is indeed concentration. In other words, there's a small subset of practices that care for a disproportionate number of dual eligible patients. And you can see this this red dashed line, this vertical line that we're calling here, and is labeled as threshold for high dual practices. But you'll notice that's very close to 80%. And on the other hand, if you look at the y-axis, it intersects very close to 20%. And so what that's telling us essentially is that there is a roughly 20% of practices that are caring for 80% of dual eligible beneficiaries. And so there is this concentration. And in some sense, that kind of contrasts to some extent with how people tend to think about safety net. I think kind of two different dimensions here. One, safety net hospitals as a concept are well established, less well established to think outside of hospitals and think about medical groups or practices caring for individuals. And then the other piece here is this high concentration that is perhaps not under-recognized or not very well recognized. And so that's really important. And we need to then kind of think a little bit harder about, so if we're trying to identify practices that might need additional resources, and those additional resources might come for a couple of reasons. It might be because they have a less preferred or financially favorable patient mix or payer mix amongst our patients. And so therefore they might be more financially strained, and or because the patients that they care for, those patients who might be underserved, more likely to be Medicaid, et cetera, they may actually have greater additional needs that extend beyond just the medical care that they're receiving. And so there might be a need for additional resources from that perspective as well. And so this, what you can take away from this chart essentially is that in the ambulatory care world, outside of hospital care, we are seeing this concentration where a small number of practices care for an outsized number of dual eligible patients. So with that kind of backdrop and that established to a certain extent, now I want to turn to our panelists. And let me start with you, Josh. And maybe you can talk through a little bit. So as we're thinking about these definitions, no definition is perfect. And we're making a trade-off between what we might call type 1 and type 2 error in the research world, but probably most importantly, where are we identifying practices where we're really confident that they are likely to be safety net, but on the other hand, we might be missing some. Or we can have a different definition that's very inclusive, but we might actually be including a lot of practices that don't have a lot of safety net populations in them. So how should we think about that from a policy perspective?
Yeah, it's a great point, Amol. And I think maybe the key point from my perspective is that, too broad risks diluting the safety net, whereas too narrow risks kind of making parts of it invisible. I think the key trade-off here is between that kind of dilution and exclusion. If the definition is too broad, I think we risk spreading limited resources across providers that may touch the safety net, but aren't really carrying, the burden or the load of safety net care to those communities that we care about. I think that makes policy potentially less targeted and harder to evaluate for policymakers. I think on the other side, if the definition is too narrow, the risk may be even more consequential. We miss providers that are essential to their communities, including rural practices, certain suburban providers, mixed systems, that may serve large numbers of patients we care about, such as dual eligibles and others, patients with low income, but they don't look like what some might consider traditional safety net institutions. So I think the key thing here would be that I wouldn't frame the goal here as finding a single universal definition. As you said, no definition is perfect. I would frame it rather as matching the definition to the policy goal or the goals. If the goal, for example, is payment adequacy, we might care about things like volume of care. If the goal is something like local access, we might care about the share of care of patients. If the goal is disparities on health equity, we may need to look at patients in certain communities more directly. But in any case, I think returning to that key point, I think too broad of a definition dilutes the safety net. Too narrow risks making part of it invisible when we want to try to make it visible. And because no definition is perfect, I think recognizing that trade-off and matching definition to goal is really the key point.
Thanks, Josh. That's super helpful. So, Paula, I'm curious. One of the challenges in health policy generally is that obviously things are dynamic, right? Things can change. So a practice that shows up in the high dual side of the threshold may not show in the high dual side of the threshold later. That's one area in which it's dynamic. And then the other area in which it's dynamic is obviously the policy windows, the politics of healthcare. All that also is constantly evolving. So Josh kind of identified trade-offs, but then also kind of flagged and said, well, we could define this based on the volume of patients, or we could just define it based on the share of patients. How should we think about this right now in the current policy environment? What do you think are areas that approaches or areas that might resonate more versus resonate less?
I mean, I love this question because I think it is trying to capture how policy aligns with dynamic forces, right? So like I'm just going to take the DISH program as like an example of a policy that started out in the 1980s to be very well targeted to safety net hospitals, not ambulatory providers, hospitals. And the statute came out in 1981. They established like clear criteria for like, how do you get DISH status? How do you not? And over time, that policy position was relaxed, and it was relaxed for a variety of reasons. Some of that was because it's hard to have a small tent, right? There were hospitals coming out of the woodwork saying, hey, I actually do a lot of safety net service, but you're not protecting me in your current in the current ways that you're defining safety net status. Then states got savvy to sort of intergovernmental transfer programs that were going on that allowed states to pull down a lot more funding that wasn't actually going to hospitals. And there were all these shenanigans that started blooming in the DISH payment program. And that has led us to like a pretty inefficiently targeted payment program these days, right? Like a really well-intentioned safety net policy that now is accessible to like 80% of US hospitals. Like, do we really think that 80% of US hospitals are safety net hospitals? Probably depends on who you ask. And so I don't have a perfect answer for your question of like what is a good way to define the safety net. I agree with Josh's point that like it requires us to be clear about our objective function. And I find that the thing that I am caring about a lot is like, what are healthcare dollars supposed to do? Which is that they're supposed to improve health for low-income people in the safety net context, right? And if there's a way for us to more directly link safety net definitions to health status of low-income people in a way that like allows resources to flow to historically uninvested places, underinvested places, rural places. I find myself trying to think about definitions more in that light. The other way I find myself thinking about definitions is that maybe we can have a static and a dynamic approach to the safety net. Maybe our static approach to the safety net is that we are okay having a big tent when we need to get safety net money out fast, right? Like let's say we had a pandemic, we needed to get out safety net money fast, but we didn't have a safety net definition, and that resulted in like 3-month payment delays to the safety net back in March of 2020. In that situation, maybe it's okay for us to be a little imprecise about who we include in the safety net versus not. In other policy situations, things like dish payments, things like more standing appropriations that we're using to get to the safety net, maybe in those cases it behooves us to be maybe a little bit narrower in our definition to prevent shenanigans, to prevent efficiencies that keep building on each other over time.
Right. That's super helpful, Paula, especially as we sort of try to place this in the context of, how do safety net definitions get used? It's not just in one context, say Medicare or a particular state's policy. This touches many different domains potentially, right? And the other thing I'd like to call out here is, we're kind of focusing in some sense around safety net definitions at the provider level. So we're thinking about safety net medical groups or practices, safety net hospitals, these kinds of ways. But there's also ways to direct resources to beneficiaries or patients direct or individuals directly, right? And we've seen the advent of some of these approaches. I think I think there's been a lot of interest that's grown, for example, the past several years in this notion of social risk adjustment. Social risk adjustment uses safety net definitions at the beneficiary level, essentially, but then allocates those resources at the provider level. So there's also this kind of mixing and matching of where are the resources going and how are the resources flowing and which kind of definition are they following. That definition could be a kind of provider-centric definition, or it could be one that's actually just about the individual patient, the characteristics of the patient. And so there's an interesting dynamism here also in terms of the central point that you flagged, which is how do we get the resources so that the patients who need care can get healthcare, right? That's ultimately kind of what this is about. So I was hoping to transition a little bit here, and Josh, I think you were going to take us through a little bit around, where does this safety net live, particularly in the ambulatory world? I think, again, we have greater sense of this on the hospital side. Clearly there's safety net, quote unquote, populations that are everywhere, but how are these providers distributed? And maybe I can hand it off to you to kind of walk us through that.
Absolutely. Maybe we could just slide forward to one more slide. Great. So, this slide really, I think, shifts us from the question that Amol has led us to consider, away from kind of who provides safety net care to a bit of a different but important question about where does that care actually occur. And so, what this map shows, just a brief context setting, is it shows the geographic distribution of clinicians practicing in what we might call high dual practices. By dual, we mean people who are eligible for insurance through both Medicare and Medicaid, a population that generally has lower income, greater health and social needs, and more complex care patterns. And by high dual practices, we mean those practices that account for most ambulatory services that are delivered to dual eligible patients. So this map is not showing where dual eligible patients live. It's showing where those providers delivering a large share of their ambulatory care are located. And the numbers you can't see here, but I'll tell you the data underlying this map, the numbers are stark. Only about 0.3% of the practices classified as high dual deliver about 80% of the ambulatory care to dual eligible patients. And so I think the key takeaway from this slide is really that safety net care is not just geographically widespread, but it's also unevenly distributed. It's not limited to just, large urban academic medical centers or institutions that some might traditionally think of the safety net. Instead, high dual practices appear across rural communities, suburban areas, mixed markets, markets with substantial variation even within the same state. And I think that variation kind of matters for policy. Safety net definitions that I think often begin with a mental model that is heavily institution focused, urban focused, reliant on things like state level averages. But I think this map helps kind of illuminate that some of those approaches could potentially miss some local realities. One community may depend heavily on a small number of high dual practices. Another community nearby may have a very different landscape for providers. And so I think it's just important and worth noting that much of this care is occurring in different settings. I'll also note that the care is occurring in traditional ambulatory settings, not just outpatient sites you might think of traditionally as safety nets, such as federally qualified health centers, rural health clinics, and the like. And that kind of helps us broaden how we think about the ambulatory safety net. So before I kind of tee up some questions for Paula and Amol, I think just want to highlight, I think this map, again, helps us understand that the safety net is both a national issue, but also a local one. It is national because the pattern is widespread, but it's also local because the access implications differ between communities. And I think the policy challenge, one of them, is to design those definitions and approaches and maybe models that are broad enough to recognize where this safety net care actually occurs, but they're also precise enough to target and support those providers and the communities that may be most at risk if that care doesn't exist. So with that kind of national, local kind of tension there, let me pose the first question to Paula here. I think this map and the data underlying it raises a question about the role of local context. And since safety net healthcare is so local and can be so community specific, in your opinion, what role do local policymakers have in supporting the safety net? How does that interact with state and federal efforts?
I mean, I think this is such an interesting question because it highlights how important hybrid governance structures are. So, like, let me take an example. One of the things I think about a lot is like safety net hospital closures. There are a lot of unprofitable safety net hospitals in the United States, but we don't let them all close, right? We let Hahnemann stay open, or sorry, we let Hahnemann close, but Temple stays open in Philadelphia. And oftentimes, all those decisions on who stays open and who stays closed, or who we allow to close, devolve to sort of very local political economy decisions. So I think the short answer to your question is that I think local and state governments are probably doing the bulk of the work in terms of keeping a lot of these safety net providers open. They're deciding when to levy provider taxes. They're deciding which facilities are worth ongoing support despite negative financial margins. But the strength of that support is only as good as the resources that they have, right? So if you are a hospital in a community that has a small tax base, because you're a small rural hospital, if you are in a place where you have a small tax base because you don't have a lot of high paying jobs, your ability to bail out the local safety net is much more muted than it is in a bigger city context. Now, I'm not gonna touch like the broader forces of like PE and other, market dynamics that are sort of upending the way that we think about some of these traditional forms of financial support for the safety net. But I find myself thinking a lot about the ability to sustain a safety net provider in a market often relies heavily on how strong their local governance is. Yes, they can apply for federal payments. Yes, they are in the habit and routine of, filling out FQHC designations or RHC designations year after year, but the more local volatility they're relying on their local governments for. And if there were ways for us to sort of strengthen those local governments, perhaps that might have a better trickle down effect to the institutions.
I really appreciate that context. So let's build on that from kind of the policy design side. So if local context is so important, and I tend to agree it is, one tempting response for someone listening to this might be to define the safety net geographically by place, by community, neighborhood, market. But it raises the question, can a place-based definition of the safety net actually work? Or does it risk potentially being too blunt and miss patients and providers that don't fit neatly into those geographic categories?
This is something I wish I had like a better answer to this question, which I think is such a good one. I find myself, so place-based disadvantage is like very real in the United States, right? Like we have persistent poverty counties in the rural South where more than 20% of the population has lived in poverty for more than like 3 decades, right? Like that's crazy. And those are like very much place-based phenomenons. How we like fix the healthcare part of that, I think is like inextricably tied to how we fix like the broader part of it. But in terms of trying to figure out like what is a good balance between like local, state, and federal policy for the safety net, I find myself looking at California a lot. I feel like California has a lot of great mechanisms in place to support their primary safety net providers that balance the resources that they get from the federal government with the mechanisms in place in the state, right? So like one thing they do is they like very narrowly target their dish payments to like only a small subset of hospitals that really serve safety net functions. They're trying to be as efficient in their targeting as possible. At the same time, they have a very generous Medicaid program so that their safety net providers are not sort of relying on the same types of volatility as like a West Virginia or other states. And so I find myself trying to think about like the positive deviance here, sort of like where are there places in the United States where perhaps the safety net is like functioning in a way that other places might be able to work toward. And I think that the dynamic in places like California, honestly, the dynamic in places like Colorado, like Denver Health, this like incredible safety net institution with a large geographic catchment that includes rural markets and urban markets, they're also doing a really good job. And so that's where I find my head trying to answer this question. Like, what are these positive deviants, these examples of like strong safety net systems that maybe we can learn something from?
Yeah, Josh, maybe I can jump in here for a second. So,
Yes.
I think Paula raises just a number of fantastic points. I would kind of echo or underscore one of the points that she makes, which is, there is quite a bit of variation in how individuals, beneficiaries utilize care, right? And so, there is become this now ever increasing phenomenon of rural beneficiaries bypassing local hospitals and going to urban centers because, presumably they're accessing higher volume centers that might offer some specialized services that they can't get in their local communities. And so one of the challenges in doing this, at least thinking about this in a very narrow place-based way, is that we might actually trade off being able to follow the patients. And if the goal again is ostensibly about getting the resources to those patients, then we risk kind of having a mismatch. And especially if those are moving targets, if things are rapidly evolving, then we might be always, as kind of policymakers, chasing our tail and trying to keep up and catch up, which is a tough spot to be in. And so I think looking at alternative approaches, looking at the different ways to think about this, the evolution certainly is starting to identify ways to do this where resources follow patients. And I think that it's worth sort of keeping those types of approaches in mind as well.
Yeah, it's a great point, Amol. Can I just build on that and ask, I mean, for those interested in that point, this idea of like where you might miss following the patients in their care, are there good data out there now? Do you think this is an area for future work? How would you guide someone who's interested in pulling that thread more?
Yeah, so I think there is, if we just take one example of this, and I don't want to over-index on one situation, but there is this notion of rural bypass of local hospitals that is actually fairly well described in the context of elective care. But actually, there's opportunities to do more work to understand how expansive that's happening and how that's impacting local hospitals and local communities as well. And so I think that is that's an area, Josh, that's kind of ripe for additional research. But there's some out there that folks could get at. I think the other thing is if you think about, when we think about variation in healthcare, I think for those of us who've been doing this for a little bit, we always tend to think of the Dartmouth Atlas, and the Dartmouth Atlas has a great amount of information that shows variation in different types of practice patterns by geographic region. But one of the interesting things is that one of the definitions that they used for markets is the hospital referral region. That is based primarily, I want to say, on a couple of specialties like cardiology and oncology, and I even think that's probably changed quite a bit. So I think there's opportunity to re-examine this. John Graves from Vanderbilt has done some really interesting work trying to re-examine how healthcare markets work. It probably varies quite a bit depending on the service that you're talking about. If you imagine people probably less willing to drive 200 miles to get primary care, maybe much more willing to do that for some kind of specialized care. But at the same time, that could vary based on where you are, which region of the country, and what access looks like. So I would say, those are a few different resources. There's literature on bypass, Dartmouth Atlas, always there, and then John Graves' work on new market definitions. Some really kind of three really good places to start looking.
Wonderful. Thanks for walking us through that. And, I think really appreciate this rich discussion on this point, which I think, again, is that safety net care is not just concentrated, but it's also geographically dispersed across the country. And I think, that makes one of the takeaway I'm having from this is that it, not only makes safety net harder to define, but also more important to define carefully. And this notion that, a purely institution-based definition may miss important providers, while a purely kind of place-based definition may miss variation that exists within regions and also may fail to follow patients who leave their own neighborhood or region for care elsewhere. So I'm gonna kind of take this moment to transition, and I'll pass it back to you in a second and just say, I think all of this brings us to a next question, which is that, once we see that safety net care is both concentrated and distributed, how should we interpret that concentration? And so, well, maybe I'll hand it to you to kind of walk us through, the distinction between thinking about that by perhaps the amount or the share of care provider delivers to safety net patients, or kind of the volume of care they provide.
Yeah, thanks. If we can go to the next slide. So we started talking about this at the beginning when I showed the Lorenz curve, and we kind of showed the concentration, the way that curve looks. It looked bent, right? It didn't look straight, and so that indicated that there is this concentration. In other words, there's a small share of practices that are caring for a lot of duals. Now, it turns out that if you think about this definition less about the number of duals that they're caring for and what share of the patients of a given practice are dual eligible versus relative to their overall Medicare book of business or their overall Medicare panel, we find that there's still a lot of concentration when you look at it from a share perspective. But very interestingly, there's a tiny amount of overlap. So now let me take, now that you kind of have that concept in your head, let's look at this chart together. So this chart basically is a y-axis and an x-axis. The x-axis is the number of ambulatory services provided to dually eligible individuals. So think about this as volume. So how much, just in a magnitude absolute sense, how much care is being provided at this practice for dually eligible individuals. And then the y-axis is of all the care being provided to beneficiaries in Medicare, what share of that is being provided to dually eligible individuals? Man, that's a mouthful. So what we see here is if we take that share, that percentage definition, the y-axis, you can see there's orange dots and the blue dots. Those are the practices that essentially are that disproportionate share. They're the ones that are really that are disproportionately caring, or at least the share of their care that's being provided is disproportionately for dually eligible individuals. If you look at all the dark blue dots, closer to black, kind of dark blue dots on the bottom, those are the ones that are meeting the definition from a volume perspective. And notably, that light blue, the overlap, those are the ones that are overlapped in their definition. And you can see that there, by my count, there are 5 dots. And that is very few dots compared to the total number of dots on this chart, which I couldn't tell you how many there are, but there's a lot there. And so what you see is that these are like definitions that partition our practices. You know, we think of both of these concepts as highly relevant to safety net. And yet we could almost take all of our practices out there and then say, let's use the share-based definition and we'll identify one group and then we'll leave out another group. And then when you flip it and say, let's look at the volume definition, we basically just flip everything upside down and say, actually, the group that wasn't the safety net is the safety net here. And the one that was a safety net no longer is a safety net. So I think this was a striking, somewhat shocking finding. I think probably most of us, at least those of us on the research team here, had hypothesized that we'd have a lot of overlap, and certainly not perfect overlap, but there'd be some outside of that. But in fact, what we found is this largely kind of partitioning the groups into two. And so that is shocking, but also then from a policy perspective highlights the importance. Again, we are the three of us. I'm going to loop Paula and Josh here and say we're all kind of nerdy policy research wonks who love this kind of stuff. But it's not just for the wonks now, right? Now it starts to become really important, because if you flip a definition, you basically flip upside down which groups you're thinking of as safety net. And if you're actually allocating dollars or have programs that are meant to target these groups, then you're getting something that could be potentially very, very different. Now, what's important here, I think also, is that it's not, I don't think anybody here would argue that these definitions are wrong, or the orange ones are clearly not safety net, or the dark blue ones are clearly not safety net. I think it comes back to something that Josh and Paula discussed earlier, which is it really depends on the policy intent, right? What is the goal? What is the goal? So Josh, let me pull you in here now. You were one of the key authors of this study, and you led a lot of this work. So as you think about this question, how do you think about the prioritization? Is there a default definition out of the share and volume that we should use? Or rather, if not, then how would you think about what are the types of policy intents that line up with each of these definitions?
Yeah, I mean, I think it's an important question, and I think at the risk of sounding like a broken record, I do think intent and goal and design should be aligned here. If I had to choose, I would say it depends on, to that end, what the problem we're trying to solve is. I think share and absolute volume are both useful, but they tell us different things about the safety net. I think share, as you alluded to, Amol, tells us something about kind of dependence and vulnerability. So if a provider has a very high share, for example, of patients that might fit into the safety net, that provider could be structurally important to access in a community, even if it doesn't serve the largest number of patients overall. And that might be, particularly relevant in rural areas, smaller markets, et cetera. So I think from a policy standpoint, I think share helps us identify those providers where financial instability could quickly become an access problem. I think absolute volume suggests something a bit different, which is, the greatest number of safety net patients where they're actually receiving care. That might matter more from a population impact, payment reform, large scale delivery system intervention perspective. I think a provider with, a low proportion or share could still be providing a large amount of care to a large number of these patients, and we want to support that. So I'd resist kind of the kind of tempting idea of kind of choosing one universal answer. I think about it a little bit kind of bifurcated and not mutually exclusive. For access protection and local market stability, share may be a very important signal. For population level investment, payment model design, absolute volume may be more important. I think the challenge is that each metrics creates a different map, as we're alluding to here in this graph, and it can create different winners and losers and blind spots if we're not careful. So I think the better approach would be to treat share and volume as a bit complementary in some ways, rather than competing definitions. A high share provider may tell us where the system is vulnerable. A high volume provider may tell us where an intervention could reach the most people. Good policy, I think, should account for both, and a provider could fit into both of those buckets, although the data suggests they may not. So I'm happy to expand on that more, but I think, again, returning to that principle of they're not mutually exclusive, but I do think intent to definition is critical here.
Thanks, Josh. That's super helpful. So, Paula, if I can pull you in as well. So, I have a couple of questions for you, and you can kind of take them in whichever order you like. I think, one thing, you are an absolute expert on thinking about hospital safety net policy. And one thing I'm curious is, as you look at this data and you think about how hospital safety net definitions look and the experience of hospital safety net definitions, like what do you take away as some of the key insights, and what can we learn from the experience on the hospital safety net side? And I think one kind of second complementary question there is one concern that's been articulated, I think, over the years around hospital safety net policy is that it tends to advantage some types of hospitals, say urban academic medical centers, for example, relative to others. And again, kind of thinking about this in the context of that policy, what are some of the dimensions or areas that we should be aware of?
So it's funny. So when I introduce myself, like to folks, I'm always like, I'm a safety net healthcare researcher, and I always have to follow that up by saying, like, I think about the safety net broadly across rural and urban contexts, inpatient, outpatient, rural, urban. But to me, this graph is like it screams the rural urban divide in the safety net. But it also reminds me of the fact that the objective functions, again, the thing that we're all saying, right? Like the goals of safety net policy in urban places might be very different from the goals of safety net policy in rural places. So let me start with hospitals and try and get at your first question. So we know that rural hospitals have struggled with financial viability, low volume since the 1980s. Like the introductions to papers in the 1980s are the exact same as the introductions to like rural hospital papers today. And we have tried to address that problem with a variety of different payment programs, right? But a lot of those payment programs fundamentally remain volume-based, right? And if you are trying to sort of drive a volume-based policy lever in places where there's population outmigration, where we know that the denominator challenge is going to be real, it's hard for those rural hospitals to sort of escape that cycle. Now, are there exceptions? Of course. Pennsylvania Global Budget, the AHEAD model, all trying to sort of try and move away from volume-based design. But I think that experiment of trying to use volume-based approaches to improve financial viability in rural hospitals, it's tough to make a strong case that that's worked for the past several decades. That might be you might very much, the way I see that connected is that I see volume-based approaches as relying on these like population-based definitions a little bit more. Let's say I have an urban safety net hospital and it's functioning in a market where there's a lot of other non-safety net hospitals. And I want to encourage the non-safety net hospitals to like not just punt all the Medicaid patients to one place. I want them to want to take care of Medicaid insured people. In those situations, it might make total sense to have a volume-based definition for the safety net to promote the goal of saying, look, if you serve Medicaid insured people, we will pay you dollars to do so. In that sense, you are aligning the volume with the reimbursement to change the incentives to serve this population. That's a much tougher sell in rural places where A, there are fewer Medicaid insured people. B, there's just fewer people all around. That incentive is just not as strong. So fundamentally, I think I'm going to wax poetic forever, and I promise I won't. But I think what this graph highlights to me is that rural safety net, urban safety net, very different beasts, very different policy objectives. And I think that just maybe I'm just re-saying what Josh already said more eloquently, which is that perhaps these definitions can align across context depending on what those specific policy objectives are. If the goal in a rural place is to keep a rural hospital open and reduce their financial volatility, let's talk about global budgets. Let's talk about things that are not like volume-based things. If the goal in a big urban city where you know you've got a lot of Medicaid insured people who might not be getting access because paying for Medicaid service just doesn't pay as much as a commercially insured person, in those situations, attaching payment and dollars to like volume-based stuff for Medicaid insured people, I think probably makes more sense.
Thanks, Paula. Yeah, I think that's super interesting, and I think the again, at risk of repeating a little bit, but I think it's worth doing, just kind of underscoring a couple of things that that Josh said, and then I think that you kind of put a finer point on in a sense, and I'll kind of elevate them again here. So if you think about, I think sometimes we think of safety net policy as a policy that's really oriented around this word access, right? Access to care, access to care. So I think there is, in some ways, a temptation to think about these volume-based definitions as following the patients where they're going in a sense. And it feels like, hey, you know what? If we're really trying to improve access for these patients, then we should reward providers who care for them. And if we reward providers who care for them in a almost a one-to-one, you increase your number of patients cared and we'll give you additional dollars, then it seems like that should work really well to actually drive access. But as you pointed out, in rural communities where there's not a lot of patients to go around in the first place, kind of by definition, right? That gets really tricky because there the access might actually mean financial sustainability of a facility, of a practice, so that way it actually continues operating or that it exists there, and so that patients actually have access to it. And there, if we use a volume-based definition, that's going to fall far short of the policy objective. And instead, we probably need to think about other ways. Now, a share-based way might be a mechanism to do that, but I think you highlighted a number of other mechanisms that might actually be even better ways to try to create a sustainable healthcare delivery sector, right? And I think this cuts across. Here we're talking about ambulatory practices, but I think there's a lot more than just ambulatory practices, obviously, in the healthcare ecosystem. So I think that was really helpful, and hopefully for the listeners here, it was really we made this concrete in terms of not only why this result is so striking in a sense, why these definitions matter, and why, quite frankly, that policy intent point that we come back to really is kind of the tip of the spear, point, I think, for all of us. So let's talk a little bit more about kind of broadly defining safety net, but now think about more about the implications. So there's a variety of different ways to think about that, or kind of categories of policy in a sense to put this into. We could think about safety net policy as, is this policy intending to target particular providers? Is it intending to target particular patients? Paula, you brought in global budgets. So how should safety net policy align or intersect, for example, with broader payment policy or payment reform changes? And I think there's a slew of questions. Before we get there, one thing I was hoping that, Paula, you could just do for us is, this is, again, not in the context of hospitals, and this highlights that, hey, what definition you choose might be very different from the ambulatory world. I was hoping you could just take one moment or a few moments and talk through what the lay of the land here looks like for hospitals. When you use different hospital definitions, do you find the same hospitals pop out over and over again? Or is it like this, where it's like really partitioned or somewhere in between?
I think it's somewhere in between. We know that inpatient care for low income people, heavily concentrated. You can produce that same Lorenz curve in the inpatient setting. The one thing that I think that is important to mention is that it depends on the measure of marginalization you choose, right? Like if you want to look at the Lorenz curve for care for dual eligibles, yes, you will get tremendous concavity. If you want to look at the Lorenz curve for Medicaid insured individuals, you will get tremendous concavity and there will be some overlap, but it will not be complete overlap in that sort of top 20% of providers. If you care about people who live in low income neighborhoods and where they get their inpatient care, again, you'll get a concave curve, but that top tail is not going to be the same group of hospitals across those different definitions for marginalization. So part of the challenge here is that people care about different things when they're talking about access. People care about different populations and different ways to identify them. And I think oftentimes what happens is that we come up with these definitions in payer specific ways. Obviously, that's how resources are dispersed, and that makes sense. But that can kind of lead to this fragmentation across definitions and then fragmentation also in terms of like who gets included in these definitions. And so I will say that the punchline on the inpatient standpoint is like, yes, there's concentration, but it's always a little bit different depending on the patient population that you are interested in defining the safety net for. And I think where I've sort of ended up on this is that wouldn't it be great if we could get consensus across payers about like how to define these populations in ways that make sense for everybody? That's hard to do because payers pay for a specific population, but I think is sort of like an essential crux of this problem. And it's also made me wonder, again, going back to a point I've made previously about are there better ways to index healthcare resources to like population health needs that are completely divorced from utilization of healthcare, right? Like you want to send healthcare resources to places where people have high mortality rates and are dying of avoidable causes of disease, right? Like that, I don't know, we're all clinicians. It feels like that should make sense, and that it rarely is how it works. And so I find myself maybe trying to be not too radical, but a little radical in like departing from some of these like utilization-based measures and saying, hey, where are clinical needs actually being perceived? And like, can we identify that in a way that we can target resources better?
Thank you, Paul. I really appreciate that. So Josh, you're somebody who's lived in a bunch of different domains in your professional life. You've you've been an executive in health systems like you are today. You've been in the policy world. You certified MedPAC. You've been an academic researcher. You've been a clinician. So you wear all these different hats. And so I think that's fantastic. Now I'm going to ask you to bring all those different brains together at the same time. And so, Paula points out this kind of important but elegant point, right? Which is essentially, well, why don't we just identify these hotspots of areas, not providers, but areas where we see a lot of avoidable mortality, avoidable bad outcomes, and let's just direct resources there. So my question to you, Josh, is so as somebody who has a lot of experience in the healthcare delivery enterprise, how would we make that work? I mean, does such a policy work in essence if it doesn't flow through the provider? Because fundamentally, if we're talking about access as one of the key goals, you would think that the healthcare delivery system has to be a central part of that. And so I'm curious if you can just reflect a little bit on this. In the back of my mind is this question around social risk adjustment also, where if we look, for example, in the current ACO REACH program, right, where there's a social risk adjustment, which means basically based off of characteristics of the population, if they are living in a higher deprivation area, then the benchmarks for these ACOs actually goes up, and in essence, financially rewarding those ACOs. But there's not, at least not to my knowledge, there's no particular requirement or guardrail that those resources are getting allocated to those individual patients, right? They could be allocated strategically to try to do as well as possible in that ACO program that may or may not directly line up with caring for that patient for whom you're getting that benchmark boost. So, Josh, a challenging question, I know, but I'm curious if you can reflect a little bit upon that's this kind of healthcare delivery system enterprise at the center of this. And does it need to be the channel for resources, or can we do something a little bit more idealistic, like Paula saying, and channel resources directly to the communities where we want to improve health?
Yeah, thanks for the easy question, Kamal. No, I think I would say I would say the healthcare system should be a channel, but I don't know that it's the channel. So not to sidestep, but I do think there are channels like the ones that Paul is talking about. But I do think that the healthcare delivery system, because it does mediate outcomes, and with respect to all the non-healthcare related things that drive outcomes that we care about, I do think it plays a key part. We can debate the number, but some proportion of it. It's also important based on these population-based models and quality and value-based models. Healthcare delivery systems are judged on those outcomes as well, right? Today, and I expect will be as well. So I think, from that perspective, the biggest implementation risk and the issue to think about is that these policies around safety net, the biggest risk is that they're built around a unintentionally simplified picture of where safety net care actually happens. That's really kind of what we've been talking about. Right? One way to summarize our conversation today is really that the data suggests that safety net care is both concentrated and distributed, concentrated among certain providers and practices, but spread across different communities, geographies, and types of delivery organizations, right? And all of that matters because I think health systems don't experience a safety net in the abstract. They experience it operationally. They experience it through attribution in panel populations, referral patterns, staffing models, care coordination needs, specialty access. They experience it through compensated and uncompensated and undercompensated care, infrastructure, as you alluded to, within and outside of payment models that are needed to serve patients, right, with complex clinical and social needs. And so that's how they experience it. And that's how they have to operate within that context. So I think if policy targets only designated safety net providers, they miss those patients that can receive care across mixed systems or outside of traditional quote unquote safety net institutions. I think if models only target patients or populations, and particularly using volume-based definitions like we've talked about, there's a risk of not giving enough stable support for those organizations to actually build and maintain an infrastructure and really a culture of care. Those clinics, care team specialists, behavioral health capacity, language services, navigation, et cetera, that you really need to make that care, the access possible. So that's a long way of saying I think there are real operational risks around that. And in fact, it extends to something that you mentioned, Amol, around, you talked about it in bypass. I think you could think about it from a delivery system in another way, that patients don't stay within one neighborhood or clinic or health system for their care. They can travel within markets, then go across markets. And so I think if policies and models can't follow those patients accurately, as you alluded to, the assignment of responsibility really becomes challenged and potentially misaligned. So in short, I think the question can't just be who counts as safety net. It's a core thing, but it can't stop there. I think other questions we have to ask is, which organizations are carrying out responsibility for those patients? What kind of responsibility are they carrying out? And then what is the infrastructure they need to do it well and the funding to do it well? So I think good policy probably needs a bit of a layered approach. Um, payment and policy focused on patient level measures probably can identify need. I think provider practice level measures can help identify where care delivery is happening. I think market level measures help us maybe see where access could be fragile, as alluded to earlier. And I think ultimately just policy that allows systems to administer, but are more sophisticated enough to administer kind of this infrastructure that we need. Because I do think, ending where we began, the healthcare delivery system does have a key role to play, not the only role, but a role to play in driving the outcomes that we in communities care about.
Thanks, Josh. So that was a very comprehensive answer. I appreciate that. And what I would say is it highlights the complexity, the layers. You said the safety net is one part, but obviously not the only part. The healthcare delivery system is a part, not the only part. And I think there are multiple layers here, and there is complexity here. And so now I'm going to go hunting for a really simple solution because it's going to make this all go away. And so now I'm curious, both of you have done work around value-based care. And so Paula, maybe I can start with you. You've done work done work, for example, about rural health models and ACOs for hospitals. And so can you reflect upon this? Like, is value-based care somehow the panacea? Is this the way that we're going to get out of this complex, sticky mess that Josh just identified? I mean, there's all these layers, there's all these stakeholders. It's appealing, I will say, to have an entity that you can say is responsible for not only the healthcare needs, but also the healthcare, the sort of health-related social needs or the non-medical drivers of health, those sort of class of dimensions. And maybe also we should have them be responsible for Medicaid enrollment and other things like that too. So, and enrollment in social services. So can we just identify an organization like that and place that expansive responsibility on them and then say, all right, we found our mechanism. But what do you think of that? Is that again kind of flawed idealistic thinking, or is there maybe a pathway there?
I'll give you a narrow answer to the value-based care thing and then a broader answer on sort of like how healthcare should interact with the social fabric. My short takeaway on value-based care, which is probably like anathema to both of you as like true experts in value-based care and like the value-based care audience at large, is that when I talk to safety net providers, organizational leaders, stakeholders about their experience implementing a variety of different value-based models, they they sort of come to the same refrain, which is like, guys, please trust that I am doing the best for this very individual patient. And can you just pay me for doing the right thing that I'm already doing, as opposed to like imposing this new set of quality measures that I need to measure and that I need to expand an EHR for that I don't have money to invest. Like, can you just look at a straightforward set of outcomes? Can we all agree on the outcomes that we care about? Like, for me, the value-based care environment and safety net context, I feel like the conversation needs to move in the direction of like subtraction as innovation, like less stuff, more focused stuff on what they are already doing well, and like they have returns to specialization on serving low-income people that go unrewarded from traditional value-based models. That like there's a way for us to better do that, and I think the answer actually lies through in like subtraction and like simplifying the value-based landscape for them. The broader question: how does the healthcare system fix all of society's ills, right? Like something that like keeps me awake at night and is like, why am I doing a Sisyphean exercise of like safety net research? But the place that I find my head these days is that, and Josh, you mentioned this, healthcare has a role to play. The question is, how big should it be? I will say that healthcare as now a dominant force in the labor sector, healthcare as a growing portion of GDP, healthcare is taking up a bigger and bigger portion of our expenditures, attention, and workforce, and we don't have the health outcomes to show for it. And I think that's a little bit of an indictment, but it makes me say, like, I wonder if policy can move in a direction that says healthcare as an industry needs to better coordinate with social infrastructure. Like, it shouldn't be that we get dollars in the healthcare system and then give it out to other people to like make sure you're enrolled in Medicaid, make sure you have access to healthy food, make sure you have access to housing. I think the answer is like, how well coordinated can healthcare be in working with those organizations that we know probably do housing, food, and employment better than a hospital will? And how can we like steward resources in those directions? It's not a convenient answer, but I do think that the answer lies in like, we should be better at talking to our friends in the social sector, and we should be able to identify what high value practices of coordination are that actually like improve patients' lives and like hospitalize them less and readmit them less and do all the things that we are claiming to care about with the millions of dollars that we're already spending. So it's not a convenient answer. I'm very sorry. But it's the one that my head is circling around these days.
I was looking for the silver bullet and you didn't give it to me, Paula, but that's
I'm
okay.
sorry.
It's okay.
I
won't
never
blame
never
you.
have it.
Josh, so as we wrap up here in our last couple of minutes, any quick points you want to make about this notion of value-based care and safety net, the kind of intersection of the policy paradigms?
Yeah, I'll be very brief here. I think Paul's echoed some of the things that I would have said. I think the first is that you know, the design and the theory of VBP, value-based payment, really should be well aligned to the care for patients in the safety net settings, but they haven't been. And I think we can point to history about ways in which it hasn't been designed, and maybe less is more, or if more is more, it should be designed and targeted in a different way. I do think when I think you mentioned the different hats that I wear, I think sometimes when I'm talking to my colleagues in the financial communities, what I'll hear a lot when we think about value-based models is this idea of risk and managing risk. When I talk to my clinician and my operational colleagues, they talk about value. And I sometimes worry that the skis, so to speak, proverbially diverging on these in some ways. And I think in an ideal world, risk is that financial mechanism that forces the system to generate the value aligned to the outcomes we talked about that we want, and values that operating model that makes risk manageable. But in reality, I think if I look back at 10 to 15 years, there are cases in which risk is a game of attribution and financial, I think, measures. And you're accepting risk, but you're not managing risk because you don't have that operational model. So I think what Paul is getting at least if I'm interpreting correctly, is really this idea of like these safety net organizations are doing things already. And so how can we recognize that and have an operational model that aligns to the risk concept in value-based care? And I think marrying those two together would be really helpful for us going forward.
Thanks, Josh. Thanks, Paula. So, wow, what a rich conversation. I'll close up here and just say, a couple of key points that folks who are listening, we want you to definitely take away from this. I think one, obviously, is that there's a lot of complexity here in the safety net landscape. What we've discussed, however, is that these definitions really matter. And, there's quite a bit of concentration in terms of a subset of providers caring for a larger set of particular patients, whether it's dual eligible or Medicaid or low income or what have you. But there's no unified definition here, and there's a lot of shifting around. And as we think about how safety net policy intersects with other types of policies like value-based care or other payment policy, there's also some complexity there. So unfortunately, no simple answers for all of you today. But hopefully some richness and some texture into what is an ongoing important policy conversation. So thanks, Josh. Thanks, Paula. We'll wrap here.